Block simulation 32. Sim process, fresh set. Read the command first, scan the clues, build fast, lock and move. 20 questions, 30 minutes. Clock starts now. Which statement about smooth muscle contraction is correct? A physiologist contrasts how SMU muscle contracts versus skeletal muscle. Read the command, which smooth muscle statement is correct. No troponin, K2 plus, calmodulin leads to MLCK, leads to phosphorylate myosin, leads to contract. Myosin light chain phosphatase relaxes. Smooth muscle contracts by a fundamentally different molecular mechanism than skeletal muscle. Critically, smooth muscle has no troponin. Instead, when intracellular calcium rises from the sarcoplasmic reticulum and from extracellular entry, K2 plus binds the protein calmodulin. The K2 plus calmodulin complex then activates myosin light chain, kinase, MLCK, which phosphorylates the myosin light chain, and only phosphorylated myosin can cycle cross bridges with actin to produce contraction. The correct answer is D. Relaxation occurs when myosin light chain phosphatase dephosphorylates myosin and intracellular K2 plus falls. This is the basis of several drugs. Nitric oxide nitrates raise cGMP, which promotes dephosphorylation relaxation, vasodilation, and the Rho kinase pathway I inhibits the phosphatase to sustain tone. Smooth muscle contraction is slower, but can be sustained with little energy, the latch state, giving graded tone in vessels, gut, and airways. It is controlled by both electromechanical, membrane potential Leacier channels, and pharmacomechanical receptor, leads to IP3, leads to SRK, release coupling, the troponin-free, K-calmodulin, MLCK contraction with phosphatase, mediated relaxation is correct. What is the diagnosis, the inheritance, and the type of dysfunction? A 17-year-old basketball player has exertional syncope and a harsh systolic murmur that increases with Valsalva and standing. Family history of sudden cardiac death. Echo shows asymmetric septal hypertrophy with systolic anterior motion of the mitral valve and LV outflow obstruction. Read the command. Diagnosis, inheritance, dysfunction. Young athlete, exertional syncope, murmur increased with Valsalva, septal hypertrophy, SAM-HOCM, autosomal dominant sarcomere mutation, diastolic dysfunction. This is hypertrophic cardiomyopathy, HCM, the classic cause of sudden cardiac death in young athletes. It is most often autosomal dominant due to mutations in sarcomer genes, commonly beta-myosin heavy chain or myosin-binding protein C. The myocardium hypertrophies, characteristically as asymmetric septal hypertrophy, producing a thick, stiff ventricle. The dysfunction is diastolic. The stiff, poorly relaxing ventricle fills inadequately. Systolic contractile function is preserved or hyperdynamic. The correct answer is A. The dynamic murmur is the high-yield exam clue. The hypertrophied septum plus systolic anterior motion of the mitral valve can obstruct the LV outflow tract, and this obstruction worsens when ventricular volume is smaller. So maneuvers that decrease preload, Valsalva, standing from squatting, make the murmur lauter, the opposite of aortic stenosis and most other murmurs. Conversely, increasing preload, squatting, hand grip, softens it. Exertional syncope and sudden death occur with outflow obstruction arrhythmia. Manage with beta blockers, avoid dehydration diuretics, screen relatives. The autosomal dominant, septal hypertrophy, diastolic dysfunction, cardiomyopathy with a Valsalva, augmented murmur is HCM. Which statement about heme synthesis porphyrias is correct? A biochemistry student studies heme synthesis in the porphyrias that arise when specific enzymes are deficient, causing precursors to accumulate. Read the command, which heme porphyria statement is correct. Glycine plus succinyl, CoA, rate-limiting ALA synthase, B6, lead inhibits ALA dehydrogenase, ferrochelatase, AIP, PBG deaminase, neurohabdominal, PCT, uroporphyrinogen, decarboxylase, photosensitive. Heme synthesis begins in the mitochondria with geolysine plus succinyl, CoA, combining to form aminolevulinic acid, ALA. The rate-limiting enzyme is ALA synthase, which requires vitamin B6, pyridoxine as a cofactor, and is feedback inhibited by heme. The pathway shuttles between mitochondria and cytosol, ending when ferroxylatase inserts ion ferrochondria, and cytosol, ending when ferroxylatase into protoporphyrin to make heme. The correct answer is C. The enzyme deficiencies define the high-yield syndromes. LEA-EO-S-zoning inhibits two enzymes, ALA-dehydratase and ferroxylatase, causing precursor buildup and basophilic stippling, microcytic anemia. Q. Intermittent. Porphyria is a deficiency of porphobilinogen. Deaminase leads to accumulation of ALA synthase. Porphobilinogen leads to attacks of the 5 Ps, painful abdomen, polyneuropathy, psychiatric changes, hot wine, dark urine, and precipitation by drugs the CY-CYP induces treat with hemin plus glucose to downregulate ALA synthase. Porphyria cutanea. TARDE is a deficiency of uroporphyrinogen decarboxylase, leads to the most common porphyria, leads to blistering photosensitivity on sun-exposed skin, with tea-colored urine. The ALA synthase rate-limiting pathway with these porphyrias is correct. Which pharyngeal pouch derivative is matched correctly? An embryologist asks what the pharyngeal, branchial, PO-uches, the endodermal outpouchings, become in the adult. Read the command. Which pharyngeal pouch derivative matches? First middle ear, second palatine tonsil, third inferior parathyroid plus thymus, fourth thymus, superior parathyroid plus C cells. The pharyngeal PO-uches are endodermal outpouchings, distinct from the ectodermal clefts and mesodermal arches, and each form specific adult structures. The first pouch becomes the middle ear cavity, a eustachian auditory tube, and mastoid air cells. The second pouch forms the epithelial lining of the palating tonsil. The third pouch is the one to anchor. It forms the inferior parathyroid glands and the thymus. The correct answer is A. The fourth pouch forms the superior parathyroid glands and the ultimobranchial body, which gives the parafollicular C cells of the thyroid. A classic trap is the parathyroids. The third pouch, more inferior structures, gives the inferior parathyroids and migrates down with the thymus, while the fourth pouch gives the superior parathyroids. The clinical correlate is DiGeorge syndrome, 22q11 deletion. Failure of the third and fourth pouches leads to absent thymus T cell deficiency and absent parathyroids hypocalcemia. The first ear, tonsil, third inferior parathyroid, thymus, fourth superior parathyroid mapping is the answer. What is the diagnosis? A patient has nephrotic range proteinuria and hematuria, a nephrotic picture. Biopsy shows a thickened glomerular basement membrane with a tram track, double contour appearance on silver stain, serum complement CC3 is LOW. It is associated with hepatitis C and chronic immune complexes. Read the command. Diagnosis: mixed nephrotic, tram track, GBM, low C3, hepatitis C, membranoproliferative GN. This is membranoproliferative glomerulonephritis, MPGN, a pattern of injury that classically straddles the line between nephritic and nephrotic, presenting with both heavy proteinuria and hematuria. The hallmark histology is a thickened glomerular basement membrane with a double contour, tram track appearance from mesangial cell interposition into the GBM, best seen on silver stain interposition into the GBM, best seen on silver stain and mesangial hypercellularity. Serum C3 complement is characteristically OW. The correct answer is E. There are two mechanistic types. TYPEI is immune, complex mediated, strongly associated with hepatitis C, often with cryoglobulinemia, hepatitis B, and other chronic antigenemia autoimmune conditions, subendothelial deposits. TYPEE, IT2 dense deposit disease, is driven by the C3 nephritic factor, an autoantibody that stabilizes C3 convertase, causing persistent complement activation. Both produce the tram track pattern and low complement. The mixed nephrotic tram track low C3 hepatitis C associated disease is membranoproliferative glomerulonephritis. Which statement is correct? A physiologist applies the renin-angiotensin-aldosterone system, RAAS, to disease and drug targets. This question targets RAAS in heart failure hypertension. Read the command. Which RAAS statement is correct? Renin leads to Angi, A leads to ACE leads to Angi leads to vasoconstriction, efferent arteriole, aldosterone, ADH, thirst, HF, activates RAAS maladaptively, ACE, ARB aldosterone antagonists help. This revisits the renin-angiotensin-aldosterone system from the disease drug target angle. The cascade, LOW renal perfusion, or low NAPLUS, or sympathetic input triggers the juxtaglomerular cells to release renin, which converts angiotensinogen to angiotensin 1, angiotensin converting enzyme EAC, abundant in the lung endothelium, converts it to angiotensin E. Angiotensin II is a potent vasoconstrictor that raises blood pressure, preferentially constricts the efferent arteriole, maintaining GFR when renal flow is low, stimulates aldosterone sodium and water retention, K+ excretion, stimulates ADH and thirst, and promotes cardiac vascular remodeling. The correct answer is B. In disease, this system becomes maladaptive. In heart failure, the falling cardiac output is sensed as low perfusion, so RAAS is chronically activated, driving fluid retention, congestion, increased afterload, and harmful remodeling. This is why blocking it improves outcomes. ACE inhibitors block. ACE leads to decreased angiotensin II, but raised bradykinin leads to cough. ARBs block the AT1 receptor and block their aldosterone. Antagonists to spironolactone, eplerenone, all reduce mortality in heart failure, and these agents plus renin inhibitors treat hypertension. The renin to angiotensin II-aldosterone cascade, maladaptive inhibitors treat hypertension. 2-aldosterone cascade, maladaptive in heart failure and block their nin-tronidalsterone antagonists as spironolactone eplerenone aldosterone antagonists. Spironolactone eplerenone all reduce mortality. Which statement about fluoroquinolones is correct? A patient with a complicated urinary tract infection is treated with ciprofloxacin. Another with traveler's diarrhea takes a fluoroquinolone. Read the command. Which fluoroquinolone statement is correct? Inhibit DNA gyrase topoisomerase 2-ice topo-IV, leads to block replication, gram. Negative atypical, tendon rupture, QT, cartilage, avoid kids' pregnancy, C. diff. Fluoroquinolones, ciprofloxacin, levofloxacin, moxifloxacin, inhibit bacterial DNA synthesis by targeting 2 topoisomerases. DNA gyrase topoisomerase 2 relieves supercoiling, the main target in gram-negatives, and topoisomerase 4 semerase 4 separates daughter chromosomes, the main target in gram-positives. They cover gram-negative rods including Pseudomonas, many atypicals, and respiratory quinolones, Streptococcus pneumonia, used for UTIs, gram-negative infections, and some GI respiratory infections. The correct answer is D. The toxicities are heavily tested. The signature one is tendinitis and tendon rupture, classically the Achilles tendon, especially in older patients, those on corticosteroids or transplant recipients. They cause cartilage damage in animal studies, so they are avoided in children and pregnancy. Other effects: QT prolongation, CNS effects, confusion, CNS effects, confusion, CNS effects, confusion, seizures, peripheral neuropathy, C, differential colitis, and reduced absorption with cations. Calcium, iron. The DNA gyrase topoisomerase, inhibiting bactericidal class with tendon and cartilage toxicity, is the correct statement. Which statement is correct? A patient with known pheochromocytoma is being prepared for surgery. This question targets the A associations and management, not the diagnosis. Read the command. Which pheochromocytoma association management statement is correct? Rule of tens, MEN2, PHLNF1, alpha block first, phenoxybenzamide, then beta, never beta first. This revisits pheochromocytoma, a catecholamine secreting tumor of the adrenal medulla, chromaffin cells, from the associations and management angle. It classically follows the rule of tens, about 10% are bilateral, 10% extraadrenal, e.g. organ of Zucker candle, where they're called paragangliomas, 10% malignant, 10% calcify, and 10% occur in cauldron. Importantly, roughly 10% more by modern testing are familial. The correct answer is C. The familial A associations are high yield, mean 2A and 2B, rep proto-oncogene, with medullary thyroid carcinoma, von Hippel-Lindau disease, VHL, with hemangioblastomas, RCC, and neurofibromatosis type 1, NF1. The management point is the classic trap. You must establish alpha blockade first, with penoxybenzamine, irreversible alpha antagonist, to control blood pressure and allow volume expansion, and only then add a beta blocker to control reflex tachycardia before surgical resection. Giving a beta blocker first is dangerous. It leaves alpha-mediated vasoconstriction. Giving a beta blocker first is dangerous. It leaves alpha-mediated vasoconstriction unopposed, precipitating a hypertensive crisis. The rule of tenth meant to VHL, NF1 associated tumor needing alpha blockade before beta is pheochromocytoma. Which organism is responsible? And the toxin. A wool sorter farmer develops a painless skin ulcer with a BLA-CAG necrotic center, a SHAR, and surrounding edema. An inhalational case has mediastinal winding and shock. The organism is a large, boxcar-shaped, gram-positive spore-forming rod with a polypeptide D-glutamate capsule. Read the command, organism, and toxin. Wolfalma, blackish shaw, mediastinal winding, boxcar gram, positive spore, formal poly-D-glutamate capsule, Bacillus anthracis, edema factor, lethal factor. This is Bacillus anthracis, a large, boxcar-shaped, gram-positive, aerobic, spore-forming rod that causes anthrax. It is unique in having a protein poly-D-glutamate capsule. Most capsules are polysaccharide, which is antiphagocytic. It is acquired from animal products, wool, hides, hence farmers and wool sorters, and forms hardy spores. The correct answer is B. The two classic forms, cutaneous anthrax, produces a painless papule that ulcerates into a characteristic BLA-CAG necrotic ES-char with marked surrounding edema. Inhalational anthrax, wool sorter's disease, causes a flu-like prodrome progressing to hemorrhagic mediastinitis, widened mediastinum on imaging, with shock and high mortality ABI terrorism concern. The virulence comes from the anthrax toxin. Edema factor is an adenylate cyclase, raises camp leads to edema, and letofactor is a protease that kills cells. Protective antigen ferries them in. Treat with fluoroquinolones or doxycycline. The black eschar mediastinal widening poly-D-glutamate encapsulated spore former is Bacillus anthracis. Which GI hormone is matched correctly to its source and action? A physiologist reviews the major GI hormones and the cell stimuli that control them. Read the command, which GI hormone matches source action? Gastrin G cells leads to acid, CCK, I cells leads to gallbladder enzymes, secretin S cells leads to bicarbonate, somatostatin, D cells leads to inhibits, GIP, K cells leads to insulin, motilin leads to MMC. The GI hormones each have a defined source cell and action. Gastrin comes from GCELS in the gastric ancrum and stimulates gastric ACI seed secretion via parietal cells and ECL cell histamine, stimulated by stomach distension and amino acid Z peptides. Chole, cystaconin, CCK, comes from I cells of the duodenum, stimulated by fatty acids and amino acids, and causes gallbladder contraction, pancreatic enzyme secretion, and sphincter of Oddi relaxation. Secretin comes from S-cells stimulated by acid in the duodenum and stimulates pancreatic and biliary bicarbonate secretion to neutralize acid. The correct answer is C. Continuing, somatostatin D cells is the universal I inhibitor. It decreases gastric acid, pancreatic and GI secretions, and most GI hormones. Octreotide is its analog. GIP, glucose, dependent insulinotropic peptide from K cells stimulates I insulin released in response to oral glucose, the incretin effect. Why oral glucose raises insulin more than IV? Maltolin, released in the fasting state, drives the migrating maltol complex that sweeps the gut between meals. Erythromycin is a maltolin agonist. The gastrin acid, CCK, gallbladder, secretin bicarbonate, somatostatin inhibition, GIP insulin, maltolin, MMC set is the answer. What are the most likely organisms and the general most common cause? A child with sickle cell disease develops fever, localized bone pain, and swelling over the femur. Imaging shows osteomyelitis. A separate IV drug user has vertebral osteomyelitis. Read the command, organisms and most common cause. Osteomyelitis, S. aureus, most common overall. Sickle cell leads to salmonella. IV drug use leads to also pseudomonas. Hematogenous children metaphysis. Osteomyelitis is infection of bone, most often spreading hematogenously, especially in children, seeding the metaphysis of long bones, which has sluggish blood flow, or by contiguous spread direct inoculation. The single most common cause overall, across most patient groups, is Staphylococcus aureus. It presents with localized bone pain, fever, swelling, and elevated inflammatory markers. MRI is the most sensitive imaging, and bone biopsy culture guides therapy. The correct answer is B. The high-yield special associations are frequently tested in sickle cell disease, while Staph aureus is still common. Salmonella osteomyelitis is the classic association, the board buzzword. IV drug users and diabetics get PSC-nominus and staph. Prosthetic joints hardware leads to staph epidermidis. Cat dog bites leads to Pasteurella. Vertebral osteomyelitis from hematogenous spread, IV drug use, and pot disease, vertebral TB, are also classic. So, Staph aureus, most common overall, Salmonella, the sickle cell buzzword. The hematogenous bone infection with Staph aureus overall and Salmonella in sickle cell is osteomyelitis. What is the diagnosis and the embryologic basis? A 3-week-old presents with bilious vomiting. Upper GI shows the duodenojejunal junction on the wrong side and a corkscrew appearance. The superior mesenteric vessels are inverted. The midgut failed to rotate and fix normally, and the bowel has twisted on its narrow mesentery. Read the command, diagnosis, and embryologic basis. Neonate, bilious vomiting, corkscrew inverted SMA vessels, failed rotation, malrotation with midgut volvulus. This is intestinal malrotation with midgut volvulus. Embryologically, the midgut normally herniates out, rotates 20-70 degrees counterclockwise around the superior mesenteric artery SMA, returns to the abdomen, and fixes with a broad mesenteric base. In malrotation, this rotation fixation fails, leaving the bowel on a narrow mesenteric pedicle, and the cecum malpositioned. The narrow base lets the midgut twist around the SMA, a volvulus. The correct answer is E. The presentation is the high-yield emergency, a neonate, often in the first week's month, with sudden bilious green vomiting. Bilious vomiting in a newborn is malrotation volvulus until proven otherwise. The twist obstructs the bowel and cuts off the SMA blood supply, threatening midgut ischemia necrosis, a true surgical emergency. Imaging shows the duodenojejunal junction displaced to the right, a corks XCW duodenum, and inverted SMA SMV. Fibrous LADD bands may also cross and obstruct the duodenum. Treat with emergent surgery, LAD procedure. The failed rotation, narrow mesentery, SMA twist with bilious vomiting is malrotation with midgut volvulus. Which statement about informed consent is correct? A surgeon plans a procedure and must obtain informed consent. The team also faces a scenario with an unconscious patient needing emergency surgery and a separate case of a 15-year-old seeking confidential STI treatment. Read the command, which informed consent statement is correct. Requires disclosure understanding capacity, voluntariness, exceptions, emergency implied, waiver, incapacity. Surrogate, minors can consent for STI, contraception, pregnancy, substance use. Informed consent is the process by which a patient voluntarily agrees to a treatment after being adequately informed. Its required elements are disclosure of the diagnosis, the nature purpose of the intervention, risks, benefits, and alternatives including no treatment, patient understanding, decision-making capacity, and voluntariness is free of coercion. It reflects the ethical principle of patient autonomy. It reflects the ethical principle of coercion. It reflects the ethical principle of patient autonomy. The correct answer is A. The high-yield E exceptions where formal consent may be waived. 1. A life-threatening emergency in a patient who cannot consent. Treatment proceeds under unplea consent. A reasonable person would want care. 2. The patient waives the right to be informed. 3. The patient lacks decision-making capacity. Then a surrogate advanced directed decision-making. Capacity is clinical and decision-specific. Then a surrogate advanced directive decides. Note, capacity is clinical and decision inspections, which is a court determination, tracking, and needed to the IV privilege. Minors generally need parental consent, but can usually consent on their own for STIs, contraception, pregnancy, prenatal care, and substance use treatment, and emancipated minors consent fully. The disclosure capacity voluntariness elements with emergency waiver incapacity exceptions and minor carve-outs is correct. Which DNA repair pathway is defective in each, and the mechanism? A child with extreme sun sensitivity develops numerous skin cancers at a young age. Cells cannot remove UV-induced pyrimidine dimers. A separate family has early colon cancer from defective mismatch repair. Read the command. Which repair pathway in each? Near fixes UV dimers, defective in XP. Mismatch repair fixes replication errors, defective in Lynch. HMPCC, base excision fixes single bases. DNA repair uses different pathways for different lesions. Nucleotide. Excision repair removes bulky, helix distorting lesions. Most importantly, the pyrimidine dimers caused by ultraviolet UV light, by excising a short oligonucleotide containing the damage and resynthesizing. Near is defective in xeroderma pigmentosa. Autosomal recessive. Patients have extreme UV sun sensitivity and develop numerous skin cancers, basal squamous cell, melanoma at a very young age, plus photophobia. The correct answer is C. Mismatch repair. RMMR corrects base matches, and small insertion deletion loops that escape the polymerase's proofreading during replication. Defective MMR, MLH1, MS2 causes Wntz S syndrome, HNPCC, early onset colorectal and endometrial cancer with microsatellite instability. For completeness, BAC excision repair removes single damage deaminated bases using glycosylases, important for spontaneous oxidative damage, and homologous recombination homologous end joining repair. Double strand breaks defective in BRCA, ataxia, telangiectasia. The NEF4. UV dimers. Xeroderma pigmentosum versus mismatch. Repair UV dimers. Distinction is the answer. What is the diagnosis and the key association? A 70-year-old woman has new bilateral aching and morning stiffness of the shoulders and hips, difficulty rising from a chair, and a markedly elevated ESR, but no true muscle weakness and normal CK. She responds dramatically to low-dose prednisone. It is associated with another condition causing headache and jaw claudication. Read the command, diagnosis, and association. Older woman, proximal stiffness, high ESR, no weakness, normal CK, steroid responsive, polymyalgia rheumatica, giant cell arteritis. This is polymyalgia rheumatica, PMR, an inflammatory condition of older adults, over 50, more common in women. It causes bilateral aching and prolonged morning stiffness of the proximal muscles, the shoulder and hip girdles and neck, making it hard to rise from a chair or lift the arms. The key discriminator from a true myopathy is that there is no real muscle. Weaknesses and CK is normal. The symptom is pain stiffness, not weakness, while the ESR and CRP are markedly elevated. The correct answer is A. Two features clinch it. First, a dramatic, rapid response to loud dose corticosteroids prednisone is characteristic and almost diagnostic. Second, the high-yield A association, PMR, is strongly linked to giant CEL, temporal arteritis. Up to half of giant cell arteritis patients have PMR, and a significant minority of PMR patients develop giant cell arteritis. So always ask about new headache, scalp tenderness, jaw claudication, and visual symptoms. Giant cell arteritis can cause irreversible blindness and needs high-dose steroids urgently. Contrast polymyositis, true proximal weakness, high CK. The proximal stiffness, high CK. The proximal stiffness, high ESR, normal CK, steroid responsive syndrome linked to giant cell arteritis is polymyalgia responsive syndrome. Linked to giant cell arteritis is polymyalgia rheumatica. Which statement about phototransduction is correct? A physiologist studies how the retina converts light into a neural signal, phototransduction. Read the command. Which phototransduction statement is correct? Dark depolarized, CGMP opens. Na plus dark current, light leads to rhodopsin, leads to transducin, leads to PDE, leads to decreased CGMP, leads to close. Na plus leads to hyperpolarized, leads to decreased glutamate, ROS dim, cones color. Phototransduction has a counterintuitive logic. Photoreceptors are depolarized in the dark and hyperpolarized in response to light. In the dark, high CGMP keeps cyclic nucleotide gated NAD+ channels open, producing a steady inward dark current that keeps the photoreceptor depolarized and releasing the neurotransmitter glutamate continuously. The correct answer is B. When light strikes, it isomerizes retinol and rhodopsin, the rod pigment, activating the G protein transducin, which activates P-alpha photoesteris, which breaks down CGMP. The falling CGMP causes the NAD+ channels to close, so the dark current stops and the photoreceptor hyperpolarizes, reducing glutamate release. That change in glutamate is the signal passed to bipolar and ganglion cells. RODS rhodopsin are extremely light sensitive and handle dim light, H night, and peripheral vision, no color. Conas handle color and high acuity central, foveal daytime vision. Vitamin A is needed to regenerate retinal deficiency, leads to night blindness. The light causes. Hyperpolarization via falling CGMP mechanism is correct time. Which statement is correct? A patient with acute pancreatitis is admitted. This question targets the CAUSs and complications, not the basic diagnosis. Read the command. Which acute pancreatitis cause complication statement is correct? Causes gallstones, plus alcohol, plus hypertriglyceridemia, hypercalcemia, drugs, ERCP, complications, pseudocyst, necrosis disinfection, RDS, hypocalcemia, hemorrhage. This revisits acute pancreatitis from the causes and complications angle. The two most common causes are gallstones, obstructing the pancreatic duct ampulla, and alcohol, together the vast majority. The fuller list is captured by I get smashed, idiopathic, gallstones, ethanol, trauma, steroids, mumps, autoimmune, scorpion sting, hypercalcemia, hypertriglyceridemia, IRCP, and drugs EIG, azathioprine didanosine. The mechanism is inappropriate activation of pancreatic enzymes causing autodigestion. The correct answer is E. The complications are high yield. A pancreatic PSC doses stock collection of fluid enzymes walled off by granulation tissue, not a true epithelial line cyst, hence pseudo can form weeks later and may rupture or get infected. Pancreatic necrosis can become infected, high mortality. Systemically, the released enzymes and inflammatory mediators can cause ARDS, a major cause of early death, and fat necrosis binds calcium complicaemia. Hemorrhage, Cullen-Gray-Turner signs, abscess, and DIC can occur. Severity is tracked with scoring systems, and elevated lipase amylase confirm the diagnosis. The gallstone alcohol caused pancreatitis with pseudocyst ARDS and hypocalcemia complications is king. Which statement is correct? A patient on warfarin is started on an antibiotic and his INR spikes. Another eats large amounts of leafy greens and his INR drops. A third needs urgent reversal before surgery. This question targets warfarin interactions and reversal. Read the command, which warfarin interaction reversal statement is correct. Inhibits BKOR, CYP inhibitors raise INR, inducers lower, vitamin K foods lower INR, reversal F vitamin K slow plus FFPPCC fast. This revisits warfarin from the interactions and reversal angle. Warfarin inhibits VI-tamin K, epoxide E, reductase VKOR, depleting reduced vitamin K, and so impairing the gamma carboxylation of factors 2, VIM, XX, and proteins C and C. It is monitored by the PTINR, not the PTT. Because warfarin is metabolized by the hepatic CYTO-strom P450 system, it has many drug-food interactions. The correct answer is D. The interaction logic is high yield. CYP450I inhibitors, e.g., many antibiotics, azole antifungals, amiodarone, cimetidine, grapefruit, slow warfarin metabolism leads to higher warfarin levels, leads to INR rises, leads to bleeding risk. CYP450, I inducers rifampin, phenytoin, carbamazepine, St. John's wort, chronic alcohol, speed metabolism, leads to Iandor falls. Dietary VI-tamin K, leafy greens, directly antagonizes warfarin, lowering the INR. For Eversol, for non-urgent over anticoagulation, VI-tamin K works slowly, hours, days for major urgent bleeding, give fresh frozen plasma or faster. Prothrombin complex, concentrate PCC, which replaces the clotting factors immediately. The CYP-driven interactions with vitamin K and VCC, which replaces the clotting factors immediately. The CYP-dimin interactions with vitamin K work slowly is the correct statement. Which congenital infection is responsible? In the classic triad, a newborn whose mother had a viral rash in the first trimester has a patent ductus arteriosus, cataracts, and sensory neural deafness, blueberry muffin rash. Read the command, which congenital infection in triad? First trimester rash, PDA plus cataracts plus deafness, congenital rubella, classic triad. This is congenital rubella syndrome caused by maternal infection with the rubella virus, atogavirus, during pregnancy. The risk and severity are highest with first trimester infection when organogenesis is occurring. The virus crosses the placenta and disrupts fetal development. The correct answer is E. The C-classic triad to memorize is 1. Cardiac defects, most characteristically patent ductus arteriosus, also pulmonary artery, stenosis, microcephaly, and intellectual disability, and other eye findings like salt and pepper retinopathy, glaucoma, and 3. Sensory neural deafness, often the only finding in later trimester infection. Other features include the blueberry muffin raster infection. Other features include the blueberry muffin, rasterdermatillary hematoba, cataracts, and other eye findings like salt and pepper retinopathy. It is a touch infection and is preventable by MMR, vaccination, a live vaccine, so given before pregnancy, contraindicated during pregnancy. The PDA, cataracts, deafness triad from early maternal infection is congenital rubella. Which statement about pattern recognition toll-like receptors is correct? An immunology student studies how the innate immune system recognizes pathogens before adaptive immunity engages. Receptors sense conserved microbial molecules. Read the command, which innate TLR statement is correct. Innate uses pattern recognition receptors, TLRs, sensing conserved PAMPs. LPS, flagellin, viral RNA, CpG, leads to NF-kappa B, leads to cytokines, rapid, nonspecific, no memory. The innate immune system provides the immediate first-line defense, and it recognizes pathogens differently from the adaptive system. Instead of highly specific receptors for individual antigens, innate cells, macrophages, dendritic cells, etc., use germline. Encoded pattern, recognition vectors Tylers, most notably the TAL. Like receptors Tylers that recognize broadly conserved microbial molecules called PAMPs. The correct answer is D. Examples of PAMPs and their sensors. LPS lipopolysaccharide, endotoxin of Gram, negative bacteria is recognized by TLR4, flagellin by TLR5, viral double-stranded single-stranded RNA, and unmethylated CpG DNA by endosomal TLRs3, 788-9 peptidoglycan lipopeptides by TLR2. Engagement triggers intracellular signaling that activates the transcription factor NF-kappa B, driving production of inflammatory cytokines TNF, IL-1, IL-6 interferons, and recruiting the response. Crucially, innate immunity is rapid, non-specific, and has no immunologic memory. That is the adaptive system's hallmark, though it instructs and activates adaptive immunity. The pattern recognition TLR sensing of conserved PAMPs via NF-kappa B without memory is correct. Block 32 is done. Let's review the 5 biggest traps from this block. Trap 1. Hypertrophic cardiomyopathy is the murmur that gets louder with Valsalva and standing, because less preload means more outflow obstruction. That's the opposite of almost every other murmur, and the classic young athlete sudden death lesion. Trap 2. Never beta block a pheochromocytoma first. Block alpha first with phenoxybenzamine, then add the beta blocker. Beta first leaves alpha vasoconstriction unopposed and triggers a hypertensive crisis. Trap 3. Warfarin runs through CYP450. Inhibitors raise the INR and cause bleeding. Inducers lower it and cause clotting. Leafy green vitamin K lowers it too. For urgent reversal, use prothrombin complex concentrate, not just slow vitamin K. Trap 4. The third pouch gives the inferior parathyroids and the thymus. The fourth gives the superior parathyroids. The lower numbered pouch ends up more inferior. Failure of both is diGeorge, no thymus, no parathyroids. Trap 5. Light hyperpolarizes photoreceptors. In the dark, cGMP holds sodium channels open. Light drops cGMP, closes the channels, stops the dark current, and reduces glutamate release. Counterintuitive but high yield. 32 blocks, 640 questions. Train process, not memorization. StepLogic, learn how to think, not memorize.